Dear friends, we are coming to the last chapter dedicated to vitrectomy, and maybe the least useful for you, since this is my personal way of designing and performing vitrectomy, and I am not supposed to be the only one to hold the truth. My only merit, if I have one, is that I have been able to build a way of doing different from what was normally recommended around the world. Is it because I had the opportunity to use the operating slit lamp, which allowed me to make different choices? Is it because the sudden influx of detachments sent by more than 500 referent ophthalmologists took me away from international congresses and thus removed me from the single thought at a time where there were not many of us to operate, and when, as pioneers, we were building our vitrectomy technique? I don't know how to say. What I can tell you is that the many visitors who have done me the honor of watching operating days, all of them, apart from the usual compliments related to their politeness, have expressed a certain astonishment about the speed, efficiency, and quality of my vitrectomies, even if I felt a certain incomprehension in their eyes. This is why, rather than showing you right away the way I conducted the procedure, and at the risk of repeating myself, because over these chapters I have already told you quite a lot of things, I will try to explain you the reasons of the choices and the little tricks I found to answer the different questions that one must ask oneself before performing a vitrectomy. These questions are: how to remove the vitreous adherent to the retina without biting and tearing the retina, how to avoid the risk of vitreoretinal ulceration, how to reduce the risk of postoperative PVR. First, how to avoid retina bites when working close to the retina. I think I've already insisted on that. The only way is to work in aspiration flow control with a very low flow in order to attract the vitreous traction without biting the retina. We can then either not to cut, obtain a pseudo-occlusion, and remove a hyoid plaque in the case of a peel, and that's why I was doing a conjunctival incision, so that the scleral depression pressing and sucking the retina gives it a strength of resistance to tearing, allowing me to easier peel, an easier peel. Or you can cut the traction exactly where you want, like a hairdresser does. So some will say, yes, but a hairdresser can also use a clipper. Okay, but in a hair clipper, there is between the blade and the skin a hoof or a screen that keeps the skin away from the blade and avoids injury. Here it's not the same. The retina is mobile and can be driven by the traction towards the blade of our handpiece. That's why, before the appearance of machines equipped with a precise aspiration flow control, we were afraid of our handpieces. And that's why the high speed was invented, and it is so reassuring for the operator. It's because it does not attract the vitreous. Alas, the corollary is that, as we have seen, it will leave a whole layer of vitreous that have not been attracted and will therefore expose the patient to the third problem, the post-op PVR. In order to avoid tears from a distance this time, my concept is the following. First of all, a central vitreous gap must be made in order to break the continuity of what I called the vitreous pancake. We have seen in the role of indentation that a release at 6 o'clock will affect the entire circumference of the pancake, provided that there has been no prior vitrectomy. Here is the same principle. As long as you have not interrupted the continuity of the vitreous pancake, when you suck up vitreous at 6 o'clock, you will be able to pull on the whole periphery. This is why I advise you to perform the central vitrectomy with a fairly fast cutting frequency, well, which for me is quite fast, of 800 to 1000 cuts a minute, so as not to risk causing tears at distance. Once this is done, and there is only a peripheral vitreous tire left, you will be able to work in a precise way, and to do so you will be able to lower your cutting frequency without being connected to the vitreous located at 2 or 3 hours away from where you work. Only then you will be able to peel off a sticky plaque or remove the entire haloid, which is perfectly impossible and dangerous if you have not previously removed the central vitreous. To reduce the risk of vitreoretinal incarceration this time, I had several tips. The first was that thanks to the slit lamp, I only had 2 sclerotomies. Moreover, as I did not use trocar, I could remove all the vitreous around the sclerotomy without being bothered by the trocar. And I did this all the more easily as my sclerotomy were placed at 11 at noon and were therefore very close to each other, and they were accessible to a tangential approach without touching the crystalline lens or indenting in front of the infusion. Finally, since it was said that the number of entries and exits was a source of incarceration, I carried out the entire vitrectomy in one go, without any exit of my handpiece, removing the vitreous around the sclerotomy thanks to the 3-mirror lens, and even doing, thanks to the slit lamp, the cryopexy of the tears during the time of the vitrectomy. When I took out my handpiece, everything was done, apart from the possible dissection of retraction. Finally, with regard of the prevention of post-op PVR, we have already talked about it. The presence of the vitreous collagen structure favors PVR. The best prevention is therefore to remove all the vitreous. At base level, of course, we cannot remove it completely, but we can try to leave very little. Thanks to the slit lamp, my second hand could make a scleral depression in the lower 300 degrees without being hindered by chandeliers, and allowed me to remove almost all the vitreous, even in front of the entrance of the handpiece in a phakic eye. The upper 30 degrees were treated without indentation with the 3-mirror lens. At the level of the adherent posterior hyaloid plaques, as I told you, my trick was to do a peel by maintaining the retina thanks to a scleral depression, but beware, this is not always easy. This is not always feasible, and this can expose to iatrogenic tears. For example, when there are already retraction nodes, when the hyaloid is embedded and integrated in the Mullerian gliosis, a peel is not possible, at least in my hands. One is then obliged to use dissection techniques, and then come two fundamental questions. The first is, how far should the dissection of retraction nodes be carried out? My position was as follows. If the nodes and the hyaloid plaque are retroequatorial, the dissection must be pushed to the maximum at the risk of creating a tear, because you have no other means of fighting retinal retractions apart from a retinectomy. On the other hand, if the nodes are further forward and can be carried by an indentation plus 4, and if you feel at some point that you are creating a tear, which will compromise the whole continuation of your dissection because the retina will tear more and more and force you to inject silicone, do not hesitate to stop the dissection and compensate for the peripheral retraction by an indentation plus 4 of the affected hemiretina. The second question is, should we systematically identify the adherent hyaloid plaques and remove them each time we do a vitrectomy for detachment? And of course, for vitrectomy indication described in the VRSRD study, because I think that there is no one defending such an attitude in the context of a systematic vitrectomy. This is an interesting question that joins the question we asked ourselves in macular surgery, which was whether we should perform a complete vitrectomy at the risk of causing iatrogenic tears in 10% of cases, which would be treated intraoperatively, or only a core vitrectomy. Here too, both attitudes can be defended and may depend on the psychology of the operator. You have very talented operators, such as Sylvia Bob, for example, who, as a perfectionist in all her vitrectomy-operated detachments, looked for hyaloid plaques and tried to remove them, even if it means peeling of the hilum of the posterior pole. This is understandable, since it has been proved by the EVRSRD study that the removal of the posterior hyaloid statistically reduces the failure in stage C1. So why not on the other stages? My position is as follows. It all depends on the importance attributed on the genesis of the detachment and in its evolution to the presence of this adherent hyaloid plaque. As you know, this is one of my hyobaists that I discovered thanks to the laser self-flare meter study that I presented in chapter 2 of this playlist. In stage C1, there are adherent plaques, as well as in stage B, and both have comparable rates of blood-aqueous barrier breakdown. But the same high rates are found in large or giant tears and in paravascular tears of the posterior pole. So I was doing a vitrectomy and hyaloid peeling in all these indications, except in some stage B, due to one or two small tears on the posterior edge of the vitreous beige, which I simply treated with a slightly protruding indentation to reverse the traction forces. I added two other indications of systematic peeling: inflammations and perforations, for which the detachment of the posterior hyaloid radically changes the consequences. As for the stage A, justifying a vitrectomy, either for optical reason, vitreous hemorrhage, capsular opacity, because of the number of or arrangement of the tears more or less staged, or for reason of space, I did not perform a systematic peeling of the hyaloid. My failure rate in this indication did not justify this gesture, which once again in my hands exposed me firstly to an injection of triamcinolone, whose perverse effects on the Müllerian gliosis I knew, but also to a rate of iatrogenic tears that frightened me. However, I knew from the laser sulfur study that a certain number of benign detachments, 12% of stage A, have complicated consequences due to hyaloid adhesion. This is why, during the central vitrectomy, I paid particular attention to the retinal flapping on the posterior pole under the effect of a rather low cutting frequency, signs of hyaloid adhesion, and if I found that, I tried on these cases to do a peel with my handpiece as I did in the macular hole. So you can see I did not have a systematic attitude, and that basically I had two ways of doing my vitrectomy. So I'm not going to show you only one film, but two films. The first one showing a complete vitrectomy, and the second showing a very complete vitrectomy. The first patient is a phakic subject presenting a small detachment due to a beautiful tear by traction, developed at the level of a lattice, and having cut a vessel which explained a small intravitreous hemorrhage. The detachment is limited and not very protruding. There is no sufficient space available to make an indentation and an injection of gas bubble, which would be essential since it is a tear by traction. Moreover, many lattices in the four quadrants present small tears that could evolve. So for reason of available volume, I decided to perform a vitrectomy. Here we are. Conjunctival incision at 2 millimeters from the limbus so that the blood does not get under the planoconcave lens. I take care to pull the conjunctiva upwards to avoid bleeding the episclera. Small light diathermy at noon and 11 o'clock, and sclerotomy with the FCI calibrated knife. Setting up the autostatic infusion and checking its intravitreous position, inserting the handpiece, switching on the slit lamp at the foot pedal and closing the coaxial light, the retina is far from the center, so I will be able to aspirate at 12 cc per minute. The vitreous is slightly hemorrhagic, Let's see if there are posterior adhesions. I decrease the cutting frequency to 500 cuts per minute. Let's see, nothing beats. The PVD is already done. And here is the vice ring. I hear the sound of the vacuum telling me that I am in the BSS. The central vitrectomy was fast. So I switch to the peripheral program and I take my strabism hook to start my scleral depression at 7 o'clock. Here it is. I aspirate at 4 cc per minute and discover a small tear in a lattice. So I lift my foot a little bit to remove the vitreous without increasing the tear. I am at 2 cc per minute. I continue my scleral depression around 6 o'clock, taking care to indent up to the ciliary body. Then I pass on the other side of the inferior muscle around 5 o'clock, and there I discover another lattice about to tear. Again, I lift my foot. I am in front of the entry point of my handpiece and I can still remove the peripheral vitreous thanks to the depression. I begin to see the big 2 o'clock tear beating. So I lift my foot to work at less than 1 cc per minute in order to have an aspiration flow that removes the adherent vitreous but which is weaker than the resistance force of the tear. At this moment, the pressure measured at the machine pump level is positive, between plus 20 and plus 50 millimeters of mercury. My scleral depression put the retina flap and sucks it, allowing me to do this precise work. I come back a little bit around 3 o'clock. And decide to treat these temporal dehiscences. So I replace my strabism hook by the cryode and perform the scleral depression with the cryode. Here we are. I press on the pedal, but the cryo is a little too superior. So I move it a little bit inferior. And this time it is good. I now move on to the big tear. Here it is. I think I am well centered. I would like to treat the whole tear with a single cryoblast to avoid expelling RPE cells. For safety reasons, I aspirate and cut at the same time, taking advantage of the fact that the retina is fixed to check that I have not left any vitreous. Okay, the tear and the two horns are well treated. I go away around noon and detect another tear that I treat at the same time. There I touch noon. I put down my cryode and ask that the plano-concave lens be replaced by the femoral lens that I hold with my left hand. In the equatorial mirror, I see the infusion appearing with a small tear just behind. I approach my handpiece all around the infusion and turn the port to suck all the surrounding vitreous. Then I do the same around the 11 o'clock sclerotomy around my handpiece entrance. I take out my femoral lens to take back the cryode while my assistant replaces the kilp lens because I want to treat this small hole I saw at noon behind the infusion. I have a little difficulties because I don't want to indent too much forward so as not to propel the infusion into the crystalline lens. Here it's done. For security reasons, I retreat this area at 12:30 because I don't know if my first treatment was sufficient. I rest my cryo and grab my strabism hook to finish my peripheral vitrectomy. I go at 10 o'clock, at 9 o'clock, and I discover these two small holes around 8 o'clock. I thus take again my cryodes and begin to treat the first zone that I had identified at 7 o'clock at the beginning of my peripheral tour, when I had to lift my foot a first time. before passing to this last zone with 2 small holes. You see it. All is carried out at the high magnification of the microscope, so nothing can be forgotten. I thus remove my handpiece. All I have to do now is to suture the 2 sclerotomies with a PDS 90 suture. Note that I did not remove the handpiece during the entire procedure. As you can see, the eye is soft because before removing the eyepiece, I pinched the infusion for 1 second. Based on the quality of my peripheral vitrectomy and retinopexy performed at high magnification, I will be able to afford to simply inject 3 cc's of SF6 diluted at 50% with my banderia technique. The 17 mm long 25G needle entered left to the gourd to remove the BSS. The 30G needle on the right injects the gas mixture until the gas comes out through the left needle, and I knew at that time that I have injected 3 cc's of the mixture. All I have to do now is to close the conjunctiva with a dithymy forceps whose intensity is controlled by the pedal. This avoids inflammatory reaction due to the suture. Thanks to the precision of the aspiration flow, and even though I took a lot of time to do a good quality cryopexy, the operation have needed only 14 minutes. I would certainly have spent 2, 3, or even 4 times more time with the venturi pump, making multiple entries and exits without performing a peripheral vitrectomy of this quality. Unfortunately, I haven't found in my video library any cases of detachment with peeling using the handpiece. In fact, I was not prepared to do this teaching during my retirement. The only posterior haloid peel that I found is this stage B case, which developed its PVD, as can be seen by the existence of this vice ring, and in which one can even see with a slit lamp on the posterior edge of the tear adherent vitreous fibrils, which I first tried to eat with the handpiece. and which I must then remove with forceps. The specimen was analyzed with scanning electron microscope, which showed that it was indeed a very typical vitreous structure. A cryogas treatment allowed the final healing. However, I do have a case of vitreous hemorrhage due to an intraocular foreign body, which shows how the posterior haloid and the anterior haloid are detached with the handpiece. The foreign body entered the eye through the pars plana but did not come out. Take a good look, it will go very quickly. I made my central vitrectomy. Then, without cutting, I plunged the port of my handpiece in the posterior vitreous to obtain an occlusion, and then I pulled the vitreous in the central lacuna. As for the macular hole, here it is. I pull, hop, hop, and then the PVD is done. Everything becomes easier. Then I have to remove the anterior haloid. I place the port of the crystalline at the crystalline equator with a flow rate of 2 to 3 cc's per minute, and thanks to the slit lamp I approach the crystalline lens without touching it until I make a hole in the haloid, and then it's done. I can easily take it off. All I have to do now is finish my peripheral vitrectomy. The aspiration coupled with the scleral depression makes the anterior vitreous descend into the port and allows to remove this vitreous without touching the crystalline lens. The foreign body is finally removed with forceps. There you have it. You know everything or almost everything about my technique. I will not tell you about dissection technique in the stage above C1, which in primary procedure detachment represents only 5.5% in the total. In fact, in France, a single surgeon could be sufficient to treat all these stages. I will not talk to you either about reoperation of failures. All these cases involve very small personal tricks and gestures that are difficult to systematize and therefore difficult to teach. All that remains for me to do is to present you with my personal strategy, trying to be as precise as possible in these cases of primary procedure detachments. This is what we will see in the following chapters.